Okay, let's start with part 2. Positioning for labor. Positions of a patient in labor has a whole lot to do with how well they tolerate labor, how well they're able to have fetal descent, how quickly their labor is going to go. It's very important to make sure that we find positions that are more comfortable for her. As she does these position changes, it can also help fight fatigue because she is changing her position. So we really need to, and it also helps improve her circulation. She gets making sure that she's moving around a lot. So a lot of the frequent position changes are we usually have them on the left side, right side, Fowler's position. We have them on their knee, chest. We have them with their legs, and there's just all kinds of tools out there that were created just for positioning for labor. When I first started having labor, all you had was the birthing ball, and you just got to play on that while you were trying to labor along. But now that you couldn't use it while you were in bed. But now they have a thing called the peanut, which it looks kind of like a big rubber peanut. You can actually put in the labor bed with them and get all kinds of different positions for your labor patient. You'll get to see all these things actually being used, hopefully, when you go to do your clinical rotation through labor and delivery. Walking, sitting, squatting, those are usually the best positions that's going to help the descent of the fetus. The contractions are usually stronger, and they are, of course, more efficient. You have a more efficient labor. And I forgot to enlarge this thing, so let's just enlarge it so you can see it better. And I'll have to look at all my other stuff, if it'll ever do it. Slow today. It's a lot quicker. It's a lot faster than it used to be. Okay, so of course, being upright, doing the walking, the sitting up. Sometimes it's difficult to keep the fetal monitor on when they're sitting or walking, but there have been a lot of strides in that field, in that they actually have Wi-Fi, so to speak, monitors that can be put on without having all the wires, and they can actually walk for certain distances while they still are on the monitor. So I think that's pretty cool. Being in that upright position is going to promote cardiac output, or being in the left or right lateral. Supine is the worst position you can possibly be in. Putting a patient in all fours, putting them, on their, like they're going to go crawling. It's going to help relieve a lot of back pain, and that's one of these positions that we can use to help rotate the fetal head around when it's in an occiput posterior position. And it's sometimes a little difficult to get mom to get in that all four, but once she gets in the all four, it really helps a whole lot. Sometimes you can actually lower the foot of the bed, and then there's the V, where the bed comes together, where the doctor can get in there and actually deliver the baby, where mom's belly fits really nicely in there. So mom can actually rest her arms and her upper body on the upper portion of the bed, while her lower body's, the baby's body, and her belly is in the lower portion of the bed, and that helps with gravity and helps the baby move. It's all about moving. Positioning her for the second stage of labor, and the second stage of labor is from complete to the birth of the baby. It can be long, it can be short. We don't really like for it to go past 2 hours, because it certainly wears mom out. It really should be up to the woman. If she wants to lie on her side, if she wants to squat, if she wants to get on all fours. I've delivered them every which way but loose. Most of your healthcare providers prefer the lithotomy position, because it's just more convenient for them. It's not whether it's more convenient for mom. It's what's convenient for them. So, of course, it can be constrained by conditions and the environment. If they are a very high risk patient and we have them on mag sulfate and or antibiotics and or Pitocin, and they are very fragile, we want to control their environment. We want to control the delivery. We would probably have an epidural, and usually with an epidural, most of the positions you see them in are in a semi-recumbent position or in a where they have their pelvic tilt going on, because the epidural doesn't work very well. If they're in an upright position, it doesn't circulate quite as well. Again, the lithotomy position is the most predominant one, where their legs are up in stirrups and they're on their back. Squatting is the best position to allow for the greatest outlet. It also has the greatest incidence of tearing because the outlet is bigger, so the baby's head comes out a little bit faster, so you will see some tearing, but it is the best position for getting the baby out. Your lateral position is going to help rotate the head. It decreases the speed of expulsion, and you see a lot of tears in that as well. So what is the best position to enlarge the pelvic outlet? Now, we don't want them in supine position. That's not going to help, is it? Lateral's not going to enlarge the pelvic. You're right, squatting. Squatting is going to enlarge the pelvic outlet. Alright, let's talk about the old labor process. The process of labor accumulates to move the fetus, placenta, and everything out of the uterus through that birth canal. Things that happen before we go into labor. We've talked about lightening. That's the descent of the fetal head in the pelvic, where mom gets to breathe but pees more. Severe, or not severe, but a lot of low back ache. Sacroiliac stress. Going to have that more urinary frequency. Braxton Hicks. Going to have the loss of the mucus plug. Remember we talked about that mucus plug forming to prevent bacteria from coming up at a certain stage during fetal development. We may see ruptured membranes. Now remember, ruptured membranes does not mean that you are in labor. It only means that your water's broke. In order to be in labor, no matter how many contractions you're having, no matter what your water's broke, no matter if you lost your mucus plug, the way you determine true labor is that you are having uterine contractions that are resulting in cervical change. If we're not having cervical change, we're not in labor. So there is no single cause or symptom that we know of that starts labor. We don't really understand what starts it. If we understood what started it, we could probably prevent a lot of preterm labor. It not only involves the uterus and the cervix, but it's also going to involve the pituitary gland as well. Pituitary gland releases oxytocin is hormone is released from there, and there's other hormones from other areas as well. Maybe uterine distension that's causing the increased intrauterine pressure, aging placenta. All these things may get together to find out if it's time for labor to begin. If we find fetal fibronectin in the secretions before the onset of labor, it helps us predict preterm delivery. If someone comes in with contractions that's preterm, and this is their third trip in, and we're like, she's tired of coming in, she doesn't know if she's in labor, it's an extra burden on the healthcare cost as well, especially if she doesn't have insurance. We can do a fetal fibronectin, which is a vaginal swab, And if it's negative, even though she's having contractions, we're 99% sure she's not going to have that baby in at least a week. So she can go home for a whole week and not worry about the baby falling out. And we can send her home without worrying about her going into labor and getting in trouble for sending her home, and then her go into preterm labor at home and have the baby at home. So fetal fibronectin is probably the best thing since sliced bread. So we do have stages of labor. A normal labor, someone who's at term, someone with no complications, only one fetus, and vertex, will usually last no longer than 18 hours. This is considered a normal stage of labor. And believe you me, not everybody fits into normal stage of labor. So, the course of the stages of labor are going to go through a regular progression of uterine contractions, the effacement and dilation, and descent of the fetal presenting part. We've already talked about all that. So, those uterine contractions is usually what starts the ball game. So we have actually 4 stages of labor. The first stage of labor lasts from the onset of having regular uterine contractions to full dilation of the cervix. It's a very difficult to assess when it begins. You'll have women say, oh, I was in labor for 4 days before the baby was born because they started having irregular contractions, so they consider that being in labor. Again, labor does not start occurring until you start seeing cervical change. But, if women come in at 4 centimeters, we don't know when they start having their cervical change. So we can only say, when did you start having contractions? The first stage of labor is the longest of all 4 stages. Well, no, I'm not going to say that, because the 4th stage of labor is the stage of recovery, and that may last a little longer, but it's much longer than the 2nd and the 3rd combined together. There are 3 phases to the first stage of labor. The latent phase, the phase where things are kind of just latently happening, not really getting exciting. You're having contractions, they're getting regular, you're feeling a little pressure in your bottom. So that's when you start seeing the effacement occur, especially again in those null tips. And then you do see in the descent, and then you have dilation of up to 3 centimeters. So it's starting out from 0 to 3 centimeters effacement occurring. Active phase is considered from 4 to 7. And I want to check with your book to make sure that they are saying the same thing, because not all of them say the same thing. Some of them will say up to 8, and we want to all be in the same page. I don't see where your book says anything. But we will cross that bridge when we come to it. But for the time being, we are going to say, and of course, we'll talk more about them when we get into the care of the patient. And then our active phase is from 4 to 7 centimeters. So the transitional stage, if I'm saying from 7 to complete, that probably will translate to 8 to complete, because it's considered when they reach 7 in the active phase, they are transitioning into the transitional phase. So basically, you just need to know that those 3 phases occur where you don't have a whole lot going on and you're just effacing out and dilating. Then you have that active phase where it's really, really painful. And then you get that transitional phase. And this is where everybody wants to throw in the towel and go home. Then the second stage of labor is from full dilation to birth of baby. It can last from 20 minutes to 3 hours, depending on if you got a primip or a multip, or if your baby's OP, or if your baby's OA. So there's a lot of things that can affect that. Remember the powers, the primary and secondary powers. So there's actually 2 phases in the second stage of labor. There's a latent phase where after the mom gets totally dilated and she's gone through that horrendous transitional phase where, oh my God, she can't take it anymore. The contractions are one on top of another. It feels like they're just never going to stop, and it's so, so painful. And then all of a sudden, she gets a reprieve. She stops having contractions. It's just kind of like a rest period. She doesn't feel the urge to push. She's just kind of getting a little bit of a breather. Then, of course, after she gets, and this may not last more than 5 or 10 minutes. It may last 10 to 20, but it doesn't last really long. Then, of course, she'll go into the active phase of love, the second stage, where those contractions come back stronger with that urge to bear down, and that fetal station is starting to advance. Then our third stage of labor is from birth of the fetus until the placenta is delivered. It can last up to an hour. We don't like for it to last up to an hour or more, because the longer it lasts, the more chances are that your mom will have problems with hemorrhage, because the uterus won't want to contract down like it should. There's some reason why it's taken the placenta so long to come out. You will see the cord elongate, kind of like a little snake there. You see movement of something you normally don't think should be moving because it's not alive, but you'll see it elongate out. You'll see a gush of dark red blood when that placenta is separating from the uterine wall. In thin women, you will actually see the uterus kind of bulge upward in the abdomen and become kind of oval shaped. You usually don't see this in women who are obese or well nourished. Then we have the fourth stage of labor. So first stage of labor is from 0 to 10. Second stage of labor is from complete to delivery of the baby. Third stage of labor is from delivery of the baby to delivery of the placenta. And then our fourth stage of labor is our recovery stage. It usually lasts about 2 hours, but we do continue to monitor, but we try to make sure for the first 2 hours we're doing a really hot shot job of doing our recovery. This is going to begin after delivery of the placenta, and it's when our homeostasis is going to be reestablished. Things we need to really watch for are is for hemorrhage, shock, and possible emboli. We definitely don't want to have any emboli going on there. So we want to make sure that we're watching for that. And hemorrhage is when they saturate a pad in more than an hour. Shock, of course, is when you're starting to see your vital signs going way down. Remember, we talked about all that fluid that mom has built up. That's her fail-safe. When she starts showing, when her blood pressure drops enough that you start seeing some signs of possible shock, she's way deep in trouble. You don't want to see this happen, and you sure don't want to see an emboli. You would rather see a thrombosis than you would a amniotic emboli, because amniotic emboli is very difficult to dissolve. So which stage of labor lasts the longest? Absolutely, it's the first. All right, let's talk about those mechanisms of labor. We have 7 cardinal movements. And these are just the movements that the baby goes through in order to come through the birth canal. So we have engagement, we have descent, we have flexion, then we have internal rotation, extension, then we have external rotation, and we have expulsion. We've already talked about engagement, how usually it occurs right before delivery in the mole tips and several weeks in the null tips. And our descent is going to actually depend on 4 different things: the pressure of the amniotic fluid, our uterine contractions, contractions of our diaphragm, and our abdominal muscles in that second stage of labor, and of course extension and straightening of the fetal body. So these are some things that descent is going to depend on. So once we have our engagement, we got to have our descent of the fetus down into the birth canal, and that's going to all depend on that. Then of course we have to have flexion. Remember I told you we want the chin to the chest. We want that baby in attitude to be in flexion. That baby's head's going to meet resistance from the cervix, so we need to have the flexion going on. Then when we get ready, when the fetus is actually to the opening of the vaginal introitus, the head's going to have to rotate. So usually that rotation begins at the level of the ischial spines, and this is where we're going to have internal rotation. The baby's head is straight up and down. It's going to have to rotate to where it comes to where it's able to go under those under the mons pubis, those bones there. Once we start seeing the baby's head in the occiput anterior position, then we start seeing extension of the fetal head. This is when it's usually deflected by that anteriorly by the perineum, and so that occiput is going to pass under that symphysis pubis first, and so the baby's head then has to extend out first by the occiput, then the face, and then the chin, and then it's going to have external rotation where you're going to see the baby's, where you see the head is going to turn either to the left or to the right, and then the shoulders are ready to be delivered, and the anterior shoulder usually delivers first, and then the posterior shoulder delivers, and then the baby is expulsionated out. So once the baby's foot clears, he's considered birthed. And this is just some cardinal movements of how it shows you. This is engagement and descent. I like to have pictures. This is where the baby's having flexion. You see the baby's head is flexing down there because her chin's flexing. This one is internal rotation. You see the baby's turning where the baby is straight away so that the back part of the head can come out. And then it flex his little head so the rest of his face comes out. Or he extends, excuse me. To me, he's flexing it as well. So that's extension. And then the baby's head is going to rotate from facing downward to either right or left. So they're born either left or right. It's also called restitution. And this anterior shoulder is ready to be born. And so he's totally rotated, and now he's almost what we call transverse. And then the shoulder, anterior shoulder, and then posterior shoulder comes out. We do have physiological adaptation that occurs both fetal and maternal. Our baby's heart rate, circulation, and fetal respirations are definitely going to change once the baby's born, but there's still some things that are, these things can be altered in labor. So how does labor affect fetal heart rate, fetal circulation, and fetal respiration? How does it affect maternal cardiac output? You can imagine that her output increases quite a bit because every time the uterus contracts, about 400 milliliters of blood is being emptied from the uterus. And of course, blood pressure is going to increase. We discourage that Valsalva maneuver unless they're pushing, and then we really don't encourage it then unless your doctor is of the traditional doctors. During labor, you're going to see an increase of the WBCs. We talked about how the white blood cell count will rise from the beginning of the first trimester to the third trimester that they will rise. Well, they will continue to increase. You would almost think that the mother was infection, but it is a response to the labor, sort of like an inflammatory response. Oxygen use, of course, is going to definitely increase, and you may see some alkalosis and some hypocapnia. So there's some things that we need to be monitoring for. The fetal adaptation is, of course, our fetal monitoring is what we are going to mainly rely on. Very few times do we do intermittent monitoring, but even if we did, we would still rely on monitoring. And we need to see, we like to see the accelerations, the early decelerations. We don't like seeing those late decelerations, and we talked about all of that in the fetal monitoring portion. Uterine contractions are going to decrease the circulation to the baby. If we got a healthy baby or a healthy fetus, then it shouldn't, labor, they should tolerate labor very well. If we have a baby that's not healthy, a fetus that's not healthy, we will start seeing those late decelerations coming up because the baby's not able to compensate for the stress of labor. And of course, respirations, we're going to see some changes in the chemoreceptors that's going to prepare that baby or the fetus for beginning pulmonary respirations. Some of those changes we're going to see is that the fetal lung's going to be cleared of the fluid that's in it. We're going to see the oxygen pressure, the PO2, decrease. Our carbon dioxide is going to increase. The arterial pH decreases. And so all of these things are going to all come together. And then in maternal changes, we talked about the cardiovascular, the 400 milliliters of blood that's going to be emptying out during contraction. We want to watch for that supine hypotension that I've talked about when that vena cava and descending aorta are compressed. So we want to make sure that they are not lying on their back. This is a big issue when we have an epidural. Of course, she's definitely going to use some more oxygen. So we already talked about that. And some of the other changes will have renal changes. She may not be able to pee. She may have 1+ proteinuria. Remember, we don't want to see any protein in her urine. We don't more than 1+ or more than 300 on 24-hour urine. We want it to be less than 300 and less than 1+. We may see an episiotomy, so we want to be sure that we are putting ice on that when she delivers. She's going to be stressed. Her musculoskeletal, she may shake. She may have some leg cramps that's going on, especially during labor. All these joints and things are going to be causing her to have pain. She's going to have some neurological changes, of course. She's going to be euphoric to serious. She may even develop amnesia. She may be elated. She may be fatigued. All these things are going to happen at one point or other during her labor. Of course, the GI, the peristalsis has already been slowed, and during labor it slows down even more. She may have some nausea, vomiting, maybe even some diarrhea. And then, of course, the onset of labor usually is triggered by decreasing hormones such as progesterone and the increasing levels of estrogen, prostaglandins, and oxytocin. Her metabolism is increased, of course, and her glucose levels may decrease simply because we don't let her have anything to eat or drink, and she's working very hard to have this baby. So we're going to stop here and to call this part 2.